first, I'd like to introduce our two speakers and panelists. So first we have Dr. Martha Ignaszewski, and she is works at UC Children's Hospital. Here an echo. Martha is a psychiatrist. She received her training at Harvard and also at UCSF. And she's board certified in adult addiction and child and adolescent psychiatry in Canada and the US. I think one interesting fact is that she is only one of 100 physicians with this subspecialty training and clinical experience in the US. So we're really delighted to have her share her information and knowledge on this topic and to really guide this conversation. And hopefully, we'll have some really lively discussion on the topic. She now works at the Complex Pain and Addiction Services at VGH. She's also the education lead and is really dedicated to working on postgraduate education for child and adolescent psychiatry at BC Children's. So thank you, Martha, for joining us. And I also want to introduce Dr. Roberto Sassi. And he is the chief of psychiatrist in chief at BC Children's Hospital. And he received his graduate training, and his medical school was from the University of Sao Paulo in Brazil. But then he completed a residency training in adult psychiatry also there and at the Massachusetts General Hospital at Harvard University in both adult and child adolescent psychiatry. And from what I understand, Roberto, you also have a PhD and have done some research in neuroimaging, and so bring also, various perspectives in terms of clinical research, kind of downstream evidence-based approaches, and you have a particular interest in mood disorders as well for adolescents and in treating that. And I think that's very closely tied to complex concurrent disorders and the use of substances. So thank you for bringing your expertise to this discussion. So, before we launch into some questions, I just wanted to set the stage. So the topic of our workshop today is safe supply for adolescents, option or risk. I think it's quite a loaded topic already in and of itself. There has been a lot of polarizing discussion, even for the adult population, about safe supply in the recent years. And I know this is in the midst of course, the overdose crisis with COVID, and that this is a new strategy and approach that has been implemented. And there's been a lot of discussion whether what kind of evidence is behind it and how to understand and also evaluate its effectiveness in the adult population. And that continues to bring, I think, a lot of differing opinions, sometimes emotionally charged as well. And I think as we bring this discussion to youth and the care of adolescents, there will be a lot of different opinions. So I just wanted to set the tone of this conversation that, we will be very respectful of everyone's opinions. We know everyone brings all your own lived experience, both from a personal level, also in your workplace. And so, we just want to remind that this will be a very respectful space and that we'll carry on the discussion with tolerance and just a lot of open-mindedness as we, share our opinions. So first, I would like to ask, Martha, you and Roberto to maybe briefly define in your understanding of safe supply. So maybe that will help also guide our conversation is what is safe or safer supply and how is this different from opioid agonist treatment?
Yeah, thanks so much for those introductions, Fiona. And I'm so glad that, Roberto and I have the opportunity to speak about this. Maybe I think what would be helpful, part of the reason we thought it would be interesting to provide a bit of a definition is this concept of safe supply or safer supply really is quite new. It's currently available in Canada. It's not available south of the border in the United States. So it may be a topic that some individuals on the call have some familiarity with and others don't. And there are some similar models of care in places in Europe. But I'm wondering if maybe while I provide a definition, if folks would be open to just mentioning where they practice or what capacity they're coming to this conversation from in the chat. And I think the other thing that Roberto and I were thinking, we're very happy to provide our perspectives and some of our opinions and information about the evidence base, but we don't come to this topic as experts. I think it's hard to say that you are specifically an expert in safe supply. It's such a relatively new concept, and especially as it's been applied to youth, has not been researched or evidenced at this point. So I think that's that's where we are open to having this be a compassionate and respectful collegial conversation where we can share perspectives of things that have gone well, challenges that have arisen, and further the conversation of all of this. So with that, I'm just going to start with a brief definition. The Canadian Association of People Who Use Drugs, CAPAD, defines safer supply as a legal and regulated supply of drugs with mind and or body altering properties that have traditionally been accessible only through the illicit drug market. And really the intention of a safer supply program is to involve the usage of prescription medications so that a safer alternative to the toxic and unregulated drug supply can be provided, really with the intention of uncoupling individuals or reducing somebody's reliance on the unregulated drug supply with the purpose of trying to reduce risk of overdose in particular. These are services that are variably implemented at this point in time. There's a number of programs across Canada, and some of these are specifically relating are specifically accessible through treatment programming or healthcare providers. That would be things like prescription opioids as part of safer supply, or stimulants or benzodiazepines. And there's other compassion clubs and programs, for example, for other substances and monitored alcohol programs that could also be viewed as safer supply. In Canada, in about August 2020, safer supply became an available option, really in the context of the COVID-19 pandemic, because there were many disruptions to the regular access of the drug supply as well as to conventional treatment, and so was viewed as a harm reduction measure to support individuals. And so it's currently supported through Health Canada through a number of projects and research projects as well.
All right.
Fiona, I wonder maybe if you could mute folks just until we're ready to kind of engage in the discussion.
I am. There's individual ones I have to just go through. If I mute all, I end up muting you too.
Oh, okay. If you want to do that, I'm happy to unmute myself.
Yeah. Okay.
Okay.
You're good.
Okay. I think the other piece that I think is just important as we talk about the definition is also to mention what safe supply is not. And it can be a little bit difficult to differentiate opioid agonist therapy, which is really viewed as treatment for opioid use disorder, from safe supply. And the reason that can be a little bit tough to differentiate is depending on the individual and the treatment approach that they're taking, if it may be harm reduction, this safe supply could play a role versus opioid agonist therapy, which really think about more conventional management. So traditionally, opioid agonist therapy has been available in an addiction medicine model, and it may align with an abstinence or harm reduction focus, but it doesn't necessarily have to. And in Canada, the treatment options that we have for opioid agonist therapy include oral medications such as methadone, buprenorphine, and slow-release oral morphine. All of which prevent withdrawal cravings and may produce some blockade at the opioid receptor to reduce the intoxicating effect of use of other opioids. And there's also injectable opioid agonist therapies like hydromorphone, diacetylmorphine, and there have been some newer strategies that sort of have not necessarily become part of the OAT umbrella at this point in time. They're more in the safe supply, things like use of intranasal fentanyl or fentanyl patches, but over time that definition may change. So I'm going to pause there and we can jump into some questions.
I don't see any questions from the audience yet, but just to follow up on all the different approaches you had mentioned, could you tell us a little bit about how available all those strategies are for youth? Like, is there a difference between youth and adults? And what they can access or what's made available?
Yeah, so I can speak most specifically to my experience in British Columbia about access to youth-based services, and I think we can generalize a little bit, but it's going to be really dependent on the location that somebody is actually specifically accessing care. Here in the Lower Mainland in British Columbia, there are a number of youth-specific services as well as adult services that support individuals that are of the adolescent and young adult age range. The further we move away from the urban centers of Vancouver and we move into suburban and rural areas, many of those services, both for mental health as well as for addiction, decrease. And that's true across the age span, but even more so for youth demographics. In BC, we're very fortunate to have longer standing programs such as Foundry BC, which is from the Inner City Youth Program. And so Foundry services many communities across British Columbia and certainly has the availability to offer some virtual services for mental health as well. But that can certainly be one of the limitations for individuals working and living in rural areas in terms of accessing subspecialty services. So there certainly is a huge reliance on family doctors and on pediatricians to really support youth and families across the substance use spectrum for access to treatment, for counseling, as well as for referrals, which we know may be tough because we have a huge shortage of primary care providers across BC.
I'll just add a quick comment. I mean, looking at the distribution of people here on the chat, that the vast majority here are calling from Canada. So most of you might be familiar with a few documents that came out over the last couple of years that have tried to frame a little bit better what safe supply is and isn't, and trying to look at the data. And I'll put some of those links in the chat. But primarily there's a report from the federal government that, as Martha mentioned back in 2020, trying to define a process of a safer supply in the context of the COVID pandemic, and how to address the risk of interruptions to the access of opioids for people that are using illicit drugs. There is also a document from Public Health Ontario trying to look at an overview of the data available. There is a report from the Simon Fraser University, from SFU, that also trying to look at the overall literature, and I'm going to put all those on the chat. And finally, there is a policy document from the Minister of Mental Health and Addictions here from BC that trying to frame how to implement safer supply in the province. The reality, as you're going to hear during the rest of the conversation, is that the data is still very limited, in particular for young people. I mean, that's in part why there's controversy. If there's enough, data, we wouldn't be having this conversation. I mean, there'll be no controversy. We will know the answer. We don't yet, but clearly this is a crisis. It's all hands on deck situation. So the idea of safer supply being an option of risk, it's more likely than not both at the same time, and we have to define how to proceed, given that we need to reduce the number of people dying because of the illicit drug toxicity.
Yeah, really well said. I will just add, so there is some emerging evidence, but still relatively little published literature altogether on the outcomes of safer supply programs. And so some of those links that Roberto will send out will be very illuminating for individuals. And in BC, across as well as a lot of Canada, most of the models are prescriber models. They're not non-prescriber models or programming that isn't part of a comprehensive program, which may actually be more in line with some other areas in the world. The proponents of a safe supply initiative show that, and I think this is consistent with other harm reduction services like overdose prevention sites and safe needle exchanges and these types of supports in the community, is that type of increased connection can allow for more wraparound supports for patients. May allow for a reduced engagement in some criminal activity and hopefully a reduced reliance on unregulated drug supply. And I live and work in the downtown downtown of Vancouver, near the downtown east side. And so I certainly hear from patients anecdotally very differing perspectives. And I don't have a lot of experience working in more suburban or rural communities. And I noticed that folks on the call may come from some of these areas. So if you have, an experience that you would like to share with the rest of the individuals, I would encourage you to please feel free to do that. Whether that's positive, whether that's been a negative or just a challenging experience and some barriers.
We had one question come up here on the chat asking about any youth-specific harm reduction sites. And then I think someone was trying to kind of follow up with saying that the Ministry of Mental Health and Addiction does maintain a list of resources as well. But if in terms of youth-specific harm reduction sites, are you aware, is there a list or a resource somewhere where people can access to find out that information?
You're on mute, Martha.
There we go. Yeah, so there are a lot of harm reduction sites across BC, and some of those are, as I said, syringe exchange programs, overdose prevention sites, social and community engagement, as well as some online applications and websites. Especially for specifically for youth, there tends to be much fewer of these than there are for adults, and they can be more difficult to access. So if folks are aware of any or want to mention some in their area, please feel free to do so. Yeah.
Okay, great. Thank you. And thank you, Roberto, for posting all the documents and the information there. I know that once the Zoom closes, people's chat closes, so I'll also migrate and I'll put those documents in the Whova, our app as well, so everyone can go back to access those resources after the conference.
Thanks, Fiona.
There's a comment from the Covenant House providing harm reduction supplies for youth. So yeah, thank you everyone for chiming in and giving all your information.
Yeah, and I'll say that the brief review the Public Health Ontario put together, the average age of a safer supply user was around on the mid-40s. So that's just an illustration of how much older the population is at this point. There has been providing more evidence in terms of safer supply. I know that the policy document from the MMHA, and I know that there's a lot of MMHA folks here on the chat, so please correct me if I'm wrong, is that the initial phase 1 launch of a safer supply here in the province will be in a relatively small number of locations, and with the expectation that the data is being collected in order to provide enough evidence for a larger implementation on phase 2. And given the numbers being primarily driven towards older adults, I'm assuming it might take a little bit of time until we have more stable data and younger adults and adolescents. But I'm ready to be corrected if anyone from the ministry feels otherwise.
Many of the overdose prevention sites have policy documents about how to support individuals who are 19 and under, as well as 16 and under, if they are presenting to these locations. So including referrals that can be made to community agencies to outreach support for individuals who may be more in a pre-contemplative state around their substance use. But there are some minimal expectations at the overdose prevention sites in terms of accepting youth, and that is a requirement to show obvious signs of drug use. Now, that's a pretty general term, I will say, that is probably open to interpretation. And my experience in working with individuals, many of these overdose prevention sites and harm reduction sites are run by, in addition to healthcare personnel like nursing, are run by peers and individuals with lived and living experience. And their intention in these situations is really to try to make the experience of using substances as safe and unstigmatizing as possible. So they do try to be mindful of working with folks that are younger and may not necessarily, put up a lot of roadblocks or barriers, which is really good. And that doesn't mean necessarily that youth who, are 13 or 15 or even 17 feel very comfortable or seeing a lot of other individuals in their own age range relative to the majority of individuals who are accessing these services. On the campus of BC Children's and Women's Hospital, a mobile overdose prevention site is actually in the process of being piloted. And that also is available for individuals of any range to utilize. It just launched very early, so it's probably not something that many individuals have heard about at this point.
I'll just add one quick thing in terms of the documents that were circulated and that tried to look at the overall evidence. Again, even though the evidence is limited, the initial data that came out from some of the places in Ontario and here in BC, it is overall reassuring. So we're not seeing in any of those sites or any of those studies that provided the data, any evidence of an increase in the number of overdoses for people that have been prescribed safer supply, which is a reassuring piece of data, even though it's limited. There is some evidence suggesting that there's an increased engagement in other components of treatment, and that's another positive and reassuring aspect as well. On the other hand, you might see in some of the reports that there is a limited understanding of the other components of care that usually surrounding safer supply, including things such as addressing homelessness and poverty and trauma and mental health concerns. Again, in part because the data is not available yet. It doesn't mean that this is not happening, but most of the studies that are reporting on the data at this moment are primarily focusing on the pharmacological component of the care and not in the other components of care, which is something that we need to do better as time goes by.
I think that's a great point, Roberto. I don't see any questions from the group yet, so I'll carry on maybe with another question, just to touch along the lines of what you were just saying about the other components of care. Could both of you speak about your experiences of working with youth and maybe youth who have suffered from an overdose, the treatment needs or the care that are required for youth in particular, how those may be different from an adult population, and whether what kind of supports are in place, or what can we do more of, if you had, the capacity to in your clinical service at the moment.
Yeah, Fiona, good question. I think in an ideal world, if we had the capacity to build programming that was specifically for youth, we would identify a number of different components. I think in a post-overdose situation, that's a real opportunity that tends to be very eye-opening, tends to be very scary for the individual, especially if this is the first time. And where I'm able to, I really want to encourage the young person to seek medical care, both because in the context of an overdose, depending on how long they were down or how long it took to receive medical care, there could be some impact on the developing brain, and we want to be able to better understand that and have a washout period. Apart from that, we want to ensure that, youth and individuals post-overdose are monitored for a period of time, because many substances, especially nowadays with fentanyl and carfentanil being the dominant opioids in the illicit drug supply, these are medications that tend to have quite long half-lives with stacked use. One-time use, they tend to be quite short-acting. But so the risk is that a medication that reverses the overdose, like naloxone, may be very effective, but the actual opioid may start to take effect and cause respiratory depression, the other symptoms of overdose. So seeking care for ongoing medical monitoring, I think, is really critical. And now that's much easier to say and recommend than it is necessarily to enforce. We don't have the capacity to force individuals to do that unless they are, clinically unwell or obtunded and there's a medical emergency to intervene there. So we need to build services that are appealing, that are youth focused and youth centered. And we can do that by helping youth connect with providers that are accustomed to working with youth, that take a developmental perspective, that are able to understand medical concerns in a way that are accessible and understandable by youth, and that are also then able to take into account the priorities and the interests of the youth. So that is a long way of saying that as we build any types of these treatment programs, I think it's critical to have the voice of individuals, and especially young people who have a history of use, living experience, to help guide the development of programming. I think peers can be really, really helpful in these scenarios. Those of us that work in the healthcare system, we already have a privileged position. There's research that suggests that we are identified as authority figures and people that are trustable and knowledgeable in terms of healthcare topics. And yet many young people who use substances may not have that same perspective of a physician or a nurse, and may see them actually as more of an authority figure or somebody that's more punitively involved. So having somebody like a peer who can support as a broker and being able to develop a shared perspective, I think is really important. Balancing the experience of precipitated withdrawal, for example, after administration of intramuscular naloxone that occurs after life-saving treatment, with reducing withdrawal symptoms and ensuring that somebody can feel very comfortable. So to provide treatment, that can be much more risky to do in the community with self-administration, but many healthcare systems are going to be very nervous to provide hydromorphone or other opioids in the setting of a post-overdose. So being able to do that in a really balanced way, and then to be able to connect youth with whatever supports or services they feel are helpful for them. And that means low barrier access to detox or to treatment, if that's what a youth is interested in, community-based treatment, mental health, housing, family supports, vocational support, educational support, all of those pieces. So to really be able to kind of weave a very integrated but wide dispersing net to be able to provide support.
Yeah, no, I agree with the very thorough response that the Martha just gave, and I'll say for people that are not aware that the BCCSU has released their youth report last, I think it was last December, if I'm not mistaken, and most of the youth there express exactly what the Martha just described, where they wanted to see supports that are low barrier, that are available very easily and rapidly, that are flexible, and that are not only focused on the pharmacological treatment, so that they do offer OT, they might offer safer supply, but they go beyond that. And that was quite a common point brought up by young people, that they don't want to be expected to be on OT or safer supply forever, for the rest of their lives. They wanted to have an end date, and use this as an opportunity to address some of the other components of their care, including, again, housing, mental health, social and cultural supports, and so on. So we need to listen to what they're saying, and make sure that we adjust our services to be as comprehensive and integrated and holistic as possible.
Yes, thank you. That was very thorough, very complete. Your answers are great, and a lot to think about, because you're listing a whole lot of options and things that need to be put in place. I see someone has asked a question about if you know of any specific youth-focused EOPS services being established. I'm thinking that means like online, like as an electronic overdose prevention sites.
Yeah, I think the E of EOPS is actually episodic. So there was a working group and a series of committees across BC to explore episodic overdose prevention sites. And these can take on various forms, including, for example, in the hospital setting, which is where I tend to work, is that somebody can use in their room. For example, they can inject substances, or if there's a place that they can safely use substances, that they're able to do that in the moment and still receive harm reduction support services. So whether that's through the provision of paraphernalia to use substances, or the substance in question, or to just be able to provide increased monitoring. I think that there have been various obstacles to really pulling that together. And I know that Vancouver Coastal Health, that's something that's still in the process of being explored on campus at BC Children's and Women's Hospital. That was transitioned to the mobile overdose prevention site as a pilot project, and things that are still being explored. Outside of these institutions, I'm not super familiar with other youth focused EOPS services. If anybody else is, or anybody from the Ministry of Health, please feel free to chime in. I'm not hearing anybody jumping out about awareness of development of youth EOP sites. But if that's something that you're interested in, there's lots of folks that are working on this, and certainly could be explored further.
I don't see any questions popping up here. I'll also make sure I don't miss any on the Whova site. No, I suppose the both of you gave such thorough responses already. I think we addressed this this topic in our time together, but I'm sure there are probably questions that are people ruminating. So you can also feel free to unmute and ask too, if it's a kind of a longer question, or you want to just kind of share your thoughts as well instead of typing it all in the chat. Please.
Yeah, no, there's a question on the chat, and let's just make a quick comment, Fiona, that when the government, both on the federal level and the provincial level, have started to consider safe and safer supply, they had a thorough ethical discussion to consider all the different principles of ethics before moving ahead with those recommendations. I mean, there is a solid argument that at this point this is a reasonable direction for us to consider, as long as, again, we're careful in terms of looking and monitoring the data. And there's a couple of different questions there on the chat.
Mm-hmm. Yeah, so first from Sue's asking what supports are available to families who are supervising safe supply in their homes. Are you aware of anything set up for that?
I mean, I think the biggest supports that I would think about are trying to ensure that families are provided, low barrier education around, what does an opioid overdose look like, so that it can be recognized very proximally, ensuring that, many individuals in the community, but especially the parents of individuals who are known to use opioids, have access to take home naloxone and have had some education about how to access that, as well as, information about when to call 911. In particular, I tend to talk with families all the time about the Lifeguard app, which can be downloaded on a mobile device, as well as the NORS.ca website, which stands for the National Overdose Response Service website. And it's a peer-run, peer-led overdose prevention hotline, similar to Lifeguard, where individuals, if you don't have somebody available to use with that can observe you and ensure your safety, that it essentially has somebody do that. They find out your location, contact information, and if something does not go well, if there's a challenging outcome and emergency services need to be summoned, that can happen immediately. So I think talking to parents about that, and I think that can be a huge really understandable worry for parents. What do you mean you're telling me I should be letting my youth use a substance like this? And the perspective that I take around this is really one of harm reduction, that if we have the awareness that this individual is going to be using substances at home in a safe environment where there is the ability to monitor them, or to do that in something like an insight, then that's going to be much safer with the ability to intervene than if they're going to be doing that otherwise. And there's plenty of memes on the internet that joke about, do you remember when mom used to call me and we were in a field somewhere drinking alcohol and we were passed out? Well, it's much safer to know what somebody is using, how much they're using of that, and to be able to intervene than the converse, which is potentially a medical emergency and the inability to respond. So I think trying to provide that kind of education, and also really meeting parents with understanding. We totally hear and understand the apprehension about those pieces, being able to get parents their own supports, so that they can process all of the anxiety and the challenges that come with living with somebody who's using with substances, parenting with somebody that's using substances, whether that's through individual counseling or group-based work as well.
Great. We have a question, probably more about the treatment trajectory or kind of recovery journey, is asking, what might be a reasonable time to let youth know that OAT will last, or that process. I don't know if it's easy to answer without knowing the patient's situation, but
I kind of approach this question relatively similarly to how I think about initiation of like antidepressants for a first episode of depression or anxiety. We can try to make it a time limited treatment. We want to try to, provide some stability. We want to try to improve symptoms, help somebody move away from some of the behaviors and the instability and behaviors that are associated with the use of substances. And I try to tell individuals, think about how long you've been using substances, or how long these symptoms have been in place. This isn't going to change or get fixed overnight. And if you need to learn different tools to manage depression symptoms, or to manage stress, or to be able to get onto a housing list, that can take realistically between 6 months to 2 years. So to go into the idea of potentially taking the medication for that period of time, I think it's really critical for any provider working with youth to be very flexible in that, and to be mindful of how they frame that, because saying this is a medication that you're going to be on forever is really not appealing to youth. And we're seeing that. That's what the evidence is showing, that youth see opioid agonist therapy as a small part and a time limited part of their treatment of their addiction. And I try to balance that and talk about population level stuff. And, can I connect you with some younger folks that have been on treatment for a long time and have done really well, and help them hear that from somebody else about what was beneficial about maintaining that medication. But it's always a choice. It's always something that's up for a revisiting and a discussion. And if it's serving you well and it's doing well, I use a lot of analogies and metaphor. If it ain't broke, do you want to fix it? Is it worth trying? We could make a small decrease, see how you do with that before taking it away entirely, and kind of temporize in those kinds of ways.
To me, that really emphasizes the importance of good clinical care, follow-up, and just that continuity, right, of really working with the patient and families. I have a question here about.
Before that, Fiona, just a quick question that I have for Martha about this topic, because most of the evidence on OAT came even before fentanyl was rampant in our communities. Right? Do you see that changes the way that OAT is implemented, or the duration of OAT, given the how different the environment is out there with the supply that we have out there on the streets right now?
So I think that that's a more complex question. I think what we're seeing is that the opioid agonist therapies that used to, and the doses that we used to be able to use to keep people out of withdrawal, comfortable, to provide some relief and blockade from intoxication, we're needing to use higher doses of medications that we had in the past. The challenge of that is it's more time consuming to get people comfortable, which is, and that's a very vulnerable period of time, the OAT titration period, especially for medicine like methadone, which the guidelines require us for safety purposes to go extremely slowly. That could be a very vulnerable and uncomfortable time for individuals that they really disengage, and they tend to be lost to follow up. So what we're seeing is the retention rates and the success rates that we have had with opioid agonist therapy in the past in a heroin era compared to a fentanyl and carfentanil era, that those retention rates are much lower. So I think that's also goes back to what youth are telling us, that opioid agonist therapy, safe supply, these may be pieces of the puzzle for help, but that's not the whole solution. And so one of my concerns about safe supply is that sometimes safe supply can be a really quick fix. We can, prescribe that pretty quickly, but if we're not finding out about how somebody is using their safe supply, how much they're continuing to engage with the toxic and unregulated drug supply, what other supports they really need, and for us to be putting in place, we're really missing the important point. And these individuals continue to be at the same high risk that they were.
Thanks, Martha.
We have a question here about whether you see a potential challenge, or maybe it's an opportunity, to offering PSS to youth through virtual care. So like virtual substitution, or
I'm not familiar with PSS as an abbreviation, or at least
I'm assuming it's prescribed safe supply.
Oh,
public safe
rather
supply.
than
I think.
the non-prescribed. Yeah.
I never use the abbreviation. Sorry. I think the idea of accessing any kind of treatment for substance use services can occur virtually. It can occur online. I do think that it's really important to start with an assessment and understand what somebody's recovery goals are. And then from there, identify treatment options that align with what the individual's recovery goals are. So I've heard about some initiatives to allow individuals to access safe supply through a quick online assessment. And I kind of liken this to quick online assessments for ADHD or anxiety medications, where you can meet with somebody for 15 minutes and have a prescription for something at the end of that, potentially sent to your home. That is unlikely to be sufficient to do a proper evaluation and to really understand where somebody is in terms of their treatment trajectory, the previous trials, and to be able to help them get connected with additional support. So I think the opportunities are that it allows for increased access, especially in these rural places where we recognize that availability of services may be more limited. And even if services are available, they may not necessarily be accessible by youth. So I think that can increase the workforce and the reach. But I think we have to be incredibly mindful. And part of that, I think we require a lot of ongoing evaluation. What are we seeing? What are the outcomes? And so that any of these decisions are being made in an evidence-based monitored strategy, so that we can, course correct or make changes as needed.
That's great, thank you. I had someone asking about the Brave app. So are you familiar with this app, Martha or Roberto? I'm just taking a look now. It's
I am not. I'm not sure, Martha, if you're familiar with this one.
No, I mean, I Googled it when it came up. Certainly, it sounds very similar to the Lifeguard app or the NORS website. I wonder if, but I don't hear people talking about this one or using this one, and I don't know if there's any good reasons for that. Who was it that mentioned it? Do you maybe want to say something about it?
Shay or Sheila. She mentioned that in the chat. Yeah, I'm just going through the app now, kind of the intro video to see.
It was introduced last year at the conference as a peer supported app.
Mhm. Yeah. Okay.
So I haven't been using this one, but I'm very happy to add something else into my repertoire to make it available to individuals who may or may not be using. Oh, and Hillary's saying that Brave actually has been the substitute for the Lifeguard app.
Mhm.
Might be the rebranding of it.
That makes sense. Yeah.
Okay, now back to kind of treatment approaches. So someone are asking about seeing Suboxone being prescribed after a hospital visit for an overdose. They're wondering your thoughts on offering OAT to youth who experience overdose or who have had an overdose but may not meet criteria for opioid use disorder.
So the rationale for that is there's a recognition that medications, in particular buprenorphine and extended release buprenorphine, may and as well as methadone and extended release morphine may all be associated with reducing likelihood of overdose. So there has been some exploration of that. In the US for individuals who do not intentionally use opioids, but there's a recognition that about 15% of stimulants in some parts of the US are contaminated with opioids, that the administration of extended release naltrexone, so an opioid blocker, could reduce the risk of overdose. So buprenorphine has taken a similar role in Canada. And it really is the idea of a harm reduction so that somebody has a reduced chance of overdosing. Now, the limitations of that is we don't actually have a specific understanding. There's no specific research looking at dosing of how much buprenorphine somebody needs to take on a daily basis to reduce their overdose risk. I've seen some community prescribers, prescribing 2 milligrams of Suboxone to patients that use stimulants with the hope that it may reduce that risk. I'm unclear how protective that ultimately is. And so I think that these types of discussions need to be balanced with potential downsides for a patient. The downsides of prescribing medication like buprenorphine for somebody who does not have an identified opioid use disorder is the likelihood of developing dependence. And I mean physiologic dependence, which is not the same as addiction to an opioid medication, which will happen within 1 to 2 weeks of taking the medication. So if there is an abrupt termination or inability to follow up with the medication, that places them at risk of withdrawal and increased chances of taking matters into their own hands to reduce the discomfort of withdrawal. We sometimes talk about opioid withdrawal not being life-threatening, where alcohol or benzodiazepine withdrawal are, but I hear from patients on a daily basis that it feels like dying would be easier than going through the experience of opioid withdrawal. So that experience is such a barrier for patients and really it reinforces the need to seek an opioid to reduce that from happening. So there may be some benefit from it, but I think that for many individuals, there can be downsides, not to mention the need to potentially go to a pharmacy on a daily basis. That can be disruptive to the day-to-day lives. There may be, issues with the administration of the medication or once monthly injections. So I think these are choices that can be talked about. They need to be made on case-by-case decisions. We certainly can't think about them on a population level at this point in time, and more research is needed. And Leanne has done a really nice job in the chat, commenting on the distinctions between Lifeguard and Brave as two separate applications or websites, and for folks to be more aware of.
There was a question a couple of chats back about how much time to get to a therapeutic dose, approximately.
Yeah. So that really depends on the medication that the individual is choosing. And therapeutic doses can look different for each of the opioid agonist therapies and can look different for each of the safe supply medications. Can also depend on what comorbidities an individual has. So somebody who has a chronic pain history or complex pain history or is on some medications, they may impact the metabolism of opioids, may need different doses than other individuals. In general, for methadone, we're at this point, we're trying to get individuals to a dose of 120 to 150 milligrams. We start at a dose of 30 to 40 milligrams and increase the dose every 3 to 5 days, or in the community, realistically, that's more like once a week, if you're able to get in to see your provider. So for methadone, it can take months to get to an effective dose. Buprenorphine, one of the reasons that I think it's particularly useful in youth is that we can do that much more quickly. And there are now protocols that allow us to prevent opioid withdrawal, initiate the medication, and get people to effective doses in hospital within the 3-day period of time. And some protocols that are being pioneered in the community that are also around that timeline, and others that can, last up to between 5 days and 2 weeks. Extended release morphine or Cadian, if you have somebody in your office and are able to devote the entire day to them and provide consecutive doses of short-acting morphine, you may be able to get to a therapeutic dose within a handful of days. And then injectable opioid agonist therapy and safe supply, these don't have the same sort of guidelines around them, so they're more made on a informed basis in using the suppression of withdrawal symptoms to determine the amount that somebody should be prescribed.
Thank you. That was very comprehensive. So we still have a few minutes. I just want to kind of hold the silence or, the space for people to still think of some questions and ask them. Or if Roberto, either you or Martha have additional kind of thoughts to add in the next couple of minutes.
No, I have to say that I'm loving the back and forth in the conversation here, because this is such an important topic. Again, we have adolescents, young people, who are losing their lives in the province and the country and North America in general, and we have now the possibility of an intervention that might be helpful where we don't fully understand the data. There's no data yet available. So this conversation among all of us, providers and young people and family members and caregivers, is so important for us to make sure that we do this right.
I will add, I think we've spoken about a lot of the advantages and upsides of safe supply. As somebody that works with youth who maybe have started experimenting with hydromorphone that has been part of safe supply, I do worry at times about the label that we have chosen for this treatment initiative. I think it can be really misleading for somebody that doesn't recognize that this is a safer alternative to the illicit drug supply, and that doesn't necessarily mean that it is safe. So I think as safe supply continues, this is something that we need to talk about with our youth. We need to talk about this as healthcare providers and in the school system. Hydromorphone 8 milligrams, which is what is Dilly-8s, many people are familiar with. That's a whopping dose for somebody that has never used opioids before. And so you need to be really, really cautious. Just as your first time drinking, you wouldn't consume a 26 ounce bottle of vodka. So I think we need to be really mindful of that. I have seen the cost of in the 2.5 years that I've been in Vancouver now, I have seen the cost of hydromorphone in a street supply driven down because so much of the safe supply is being diverted. There's lots of ways to interpret that if more people are accessing it, there's reduced reliance on the unregulated supply, which may be beneficial. But it's now costs $1 for a tablet of hydromorphone. And I've seen students from UBC who had pain or other issues were able to access it and went on to develop de novo opioid use disorders. I've also heard, which for me is really scary, that some individuals are looking for evidence-based treatment. They really are looking for recovery. They want to get into treatment or onto opioid agonist therapy and are offered safe supply without the evidence-based opioid agonist therapy. And that puts them in a perhaps safer but different cycle of addiction. And so I think I think we need to be balanced as we have these conversations. We need to think about the advantages. We need to think about the unintended consequences and be very selective, very judicious about who is accessing this, how that's going, and also how we are continuing to research this, because I think that is one of the pieces. This shouldn't be an opinions-based decision or a philosophical discussion. This really should be a discussion about what does the research show us? What are the positive outcomes? What are the challenges? How do we mitigate those and reduce that risk? And I see Angie asking me a really important question. I know Angie very well, inquiring, if your 15-year-old had an opioid use disorder and didn't want treatment, would my first choice be to put them on safer supply? And my short answer is probably not. I would be working with them on trying to get them, trying to understand what is the driver of their use, what the benefit that they are perceiving of their substance use, what other factors are contributing to that. I may think about trying to get them into a higher level of care, working with their families to reduce risk and all of those pieces. But I'm always trying to get somebody into an evidence-based known treatment such as opioid agonist therapy, inpatient residential, what have you. But I am happy to know that I do have safe supply available as a backup option if that's what's going to get that individual back into my option to keep talking to me, keep them alive, to be able to continue that discussion. And I think that's where harm reduction is really, really critical.
Yeah, I don't see any other questions on the chat.
Yeah, I mean, I noticed we're close to the end of our workshop time. I will, like I said, move the documents of, oh, nope, there's a question popped up. Are there any provincially available doctors to help you with substance use disorder, particularly for those without doctors?
There certainly are resources for, I'm not sure if this is referring for individuals who use substances to be able to access, or if it's for healthcare providers to try to get some more support. I will say both are available. So
they clarify.
Oh, for youth, yeah. So there are a number of hotlines as well as central intake addictions team where you can actually reach out, call, and they can let you know about what services are available, how to access those, and to think about those specific to your community as well as further. So that can be really, really helpful. Many of the health authorities have, some more information about youth specific services. I know Vancouver Coastal Health has an intensive case management team for youth. There's now a new outreach team for youth on the downtown east side. Many of the foundries will have some outreach services. And there's also services such as like Anya, for example. So for youth who are indigenously identified, can get some support through outreach workers to get connected with services as well.
Mm-hmm.
Foundry is in the process, Sheila, of working on developing for every Foundry Center to have OAT providers, and that should be, I don't know exactly the timeline for that, to be able to to have OAT prescribers. Sorry, my sentence is falling apart. Foundry is in the process of expanding their services so that every Foundry Center will be able to prescribe opioid agonist therapy. And to be able to do that virtually, so that if individuals are in centers where there aren't addiction doctors who are taking on new patients or live in an under-resourced community, that isn't necessarily the barrier. Which I think is really important. I think the piece that I'm really mindful of, I think it's really easy, or it can be quite easy to get somebody started on treatment. But if our youth are telling us we don't want to be on this forever, what are we doing in order to be able to retain them in treatment, help them maintain that stability, and support them in ways that things are helpful? So I just go back to that premise that opioid agonist therapy, while a really helpful tool in your toolbox, is not the whole story when it comes to opioid use disorder.
Mm-hmm. Yeah, and all the pieces you had mentioned earlier, and psychiatric care and treatment and support and family. Yeah. All right, so I think we're at the end of our time. This was so informative. It was wonderful. Thank you so much for your insight and very comprehensive explanations for all the approaches, and such a thorough answer of all the questions. I hope everyone in the session today enjoyed it as much as I did. And it will be available online as well. So the session is being recorded, and all the information will be transferred over on Whova too. So all the documents.
Thanks so much, everybody.
Thank you so much. Okay, enjoy the rest of the conference.
Bye.